Clinical Journal Club in English. In the New England Journal, the mystery image of the week concerns this 39-year-old man who presented to an emergency department with belly pain and constipation. He was examined, and a striking physical finding is shown here. We see his teeth, they're in place. They don't even look all that diseased, at least not from this vantage point. And there is a dark line that separates the base of each tooth from the gingiva. And we are offered a differential diagnosis, scurvy, vitamin C deficiency. In that condition, the teeth fall out, and these are all in place. Bismuth poisoning, no idea. Adult Still's disease is not a disease of the mouth. Behcet syndrome is characterized by ulcer formation and this sort of thing inside the mouth. We don't see those. And lead poisoning features pain, abdominal pain, constipation, and these lead lines that can be seen at the border between the teeth and the gingiva. So the diagnosis here is lead poisoning. This is a classical physical finding. We don't see this very much anymore. When I was a junior physician at Indiana University, we had a large battery factory nearby that produced car batteries, which was a common source. Another common source in those days was older wooden houses that had been painted in the 1920s with lead paint and this sort of thing. But this looks like an example of lead poisoning. And that's the correct answer. This poor devil was chewing opium, and in order to make the product heavier, since it's sold on the basis of weight, his dealers laced it with lead, which indeed made the product heavier, caused these lines. So this is treated with chelation therapy, EDTA, and that should help the problem. Now, what the persons presenting this patient probably don't know is that bismuth can cause the same thing. Bismuth is used therapeutically in patients with Helicobacter pylori infection, but there it's given orally and it's resorbed hardly at all, rather similar to barium sulfate, so that's no problem. But in the 1920s, syphilis was treated with bismuth injections. And those patients also exhibited a line, shown here, a bismuth line. So actually, bismuth should be almost an acceptable answer if this were 1940, but this is 2018, so the answer is lead poisoning. The first paper in the New England Journal is another rehash of this study that we looked at somewhat over a year ago. This was a cardiac catheterization percutaneous intervention study in patients with cardiogenic shock. Now, these patients were in shock in that they had a systolic blood pressure under 90 millimeters of mercury for more than 30 minutes, required catecholamines to maintain their blood pressure, had pulmonary congestion and signs of impaired organ perfusion. Now, these patients need to go to the coronary catheterization laboratory immediately. And then is the question, what to do? The therapeutic avenue of choice is, of course, to find the culprit lesion and to open it and stent it. Now, patients that have atherosclerosis to this degree commonly also have other blood vessels that are involved. And if the cardiologist spends his time fixing all of them, instead of perhaps dealing with the patient's shock, it could cause a different spectrum of risk. So in this study that we've already seen before, at 30 days, the patients who only had their culprit lesion addressed and were otherwise left alone did better than the patients that spent more time in the catheterization laboratory getting all their vessels fixed. Now we look to see what happened to these patients at 1 year. And what we see here are the patients, fairly small study, 70 patients in each group. These are older persons, mostly male, past history of smoking, hypertension, diabetes, all of the things that are associated with severe coronary artery disease, and the vessels that were involved, right coronary artery, left main, circumflex. This is big vessel disease. So those are the patients. And here's an example. Here's an occluded culprit artery. And here's a right coronary that's barely open. So these are the kinds of lesions that were treated in this study. And as we learned already, at 30 days, the patients that only had these big lesions treated that were otherwise left alone did better than the patients that had all their coronary lesions that might be warranted fixed. And here we look at these patients in terms of what sort of stent they got and their medications and these various things and their antiplatelet therapy and those things, those items were similar in the groups. Although there were some significant differences, complete revascularization achieved. That, of course, was only done in the patients that had all their blood vessels fixed. Non-culprit lesions were the ones that were fixed in everybody that had all their vessels fixed, and not in the patients who only had their main problem addressed, etc. So those kinds of variables were differed between the groups as was intended in this study. Now, what we see here, death from any cause, renal replacement therapy, death from recurrent infarction, and this sort of thing were similar. Rehospitalization for congestive heart failure was different, and that was more common in the, this is at 1 year now. This was more common in the patients that only had their culprit lesions fixed as opposed to the patients that had all their blood vessels fixed. We might imagine that this would be the case for several reasons that we can discuss. Now, here's the time to event analysis. These are the data at 1 year. Patients that had their culprit lesions fixed only did better at 30 days compared to the patients with multivessel disease. And this difference was sustained, but in a so-called post hoc landmark analysis, I don't know exactly what landmarks they're talking about, but that's what they call it. We see that the mortality was similar in the two groups as shown here, and then there's no longer a difference within the two groups. But what was different in the study is, and that's shown here, not very many, but the culprit lesion only patients ended up having to come to the hospital more often for complications compared to the patients that had all their blood vessels fixed. Now, when we look at this kind of forest plot here, one thing that springs out is the patients that had multivessel repair immediately, the ones that really seemed to profit from it seemed to be the patients that were in cardiogenic shock that were less than 50 years of age. And we might imagine these patients are the ones that tolerate shock better as compared to the people that are 80 years old. So the 80-year-old patients, they were probably better off. They had a more chance of being alive at 30 days if they only have their main lesion fixed. But the patients that were younger, that had vessel disease, would appear to have profited more from having all their vessels fixed at the first session compared to other strategies. Now, the next topic is checkpoint blockade, sort of checkpoint Charlie. We've heard of all of this before. There were 2 Nobel Prizes given for this strategy that involved programmed death protein 1 and CTLA4. That issue involves lymphocytes. This is a checkpoint that involves macrophages. And the checkpoint here involves CD47. And the tumor cells that express CD47 are not attacked by macrophages, even though the tumor cells might have an eat me signal. So CD47 regulates eat me signals so that our macrophages don't eat everything. So what was developed in this study was an antibody against CD47. And the idea here is to block CD47 on the tumor cells so that macrophages will eat these tumor cells. Another form of checkpoint blockade. And in this study, we look at patients with refractory lymphoma that have already gone through CHOP plus rituximab and these kinds of things and other previous treatments. And their B-cell lymphomas have nevertheless progressed. So what was done here is patients were treated with refractory lymphoma. This is not a randomized trial. All the patients here, because their outlook was so bad, were treated with this CD47 antibody to try to block this checkpoint so that their macrophages would eat their lymphoma cells. And so eligible patients, severe lymphomas that have had 2 previous therapies, flunked that, tolerate rituximab, and so here we go. First thing that we look at is adverse events. Now, these patients have terminal lymphoma anyway, so that if they get some insomnia or have some dyspepsia or constipation, probably won't bother them too much. So the grade 1 adverse events are fairly common. Severe grade 4 adverse events, that would be the orange color, we hardly see those at all. What we do observe is anemia, and hemoglobin values dropped in these patients. It turns out that erythrocytes express CD47. So the erythrocytes ended up being eaten, but that only applies to old erythrocytes and not new erythrocytes. You'll recall that erythrocytes have a survival expectancy of 120 days. So if we eat all the erythrocytes that are older than 100 days, we should probably get our reticulocytes going, and it should not be a lethal complication. We see some dramatic reversals of lymphoma. Here's a complete response at 8 weeks. The darn thing is gone. And that's shown in this PET analysis here. So some patients responded great, but that was not the case for all patients. That was only the case for, actually, a majority of the patients had a pretty good response, but not all of them. So objective response, at least half of them. Complete response, 36%, not bad. Partial response, 14. We can add all these up, but there are some patients that nevertheless had progressive disease. And that's shown, this is a so-called waterfall plot, and the right hand, the responders outnumber the non-responders, but nevertheless, it's not a controlled trial. Some patients got worse, but a substantial number of patients seem to be responsive to this therapy. So in this phase 1b study, this checkpoint inhibitor for macrophages was actually looked pretty impressive. The adverse events were acceptable, aside from the fact that the old erythrocytes got eaten. And so this is another example of checkpoint therapy in patients with refractory malignancy. The next topic in the New England Journal has to do with idiopathic pulmonary fibrosis. That's abbreviated IPF. The etiology of this condition is not known. It strikes patients in their middle years. Women are involved a little more commonly than men. The patients develop a horrible bilateral lower lobe refractory chronic pneumonia without resolution that results in fibrosis. Their pulmonary function deteriorates, their transfer capacity for carbon monoxide gets worse, and they die. They commonly also get phalangeal clubbing, that's shown here, which is also a hallmark of this condition. Now, this disease has only one approved therapy to my knowledge, and we'll look at that in a moment. The difficulty is in assessing the progression of this disease. I would have preferred the 6-minute walk test, but that wasn't done. What was applied here was the St. George's Respiratory Questionnaire. There are 50 questions in this questionnaire, and it addresses symptoms, patient's activity, impact on quality of life, as well as a total score. So what was required in this study is the patients had to at least get 4 points better before this was deemed to be a significant response. St. George. Now, the treatment that's given these patients is a tyrosine kinase inhibitor, nintedanib. Nintedanib deals with VEGF signaling, fibroblast growth factor signaling, PDGF signaling, and blocks these tyrosine kinases, and it also functions in patients that have lung cancer. exactly why this therapy seems to work in patients with idiopathic pulmonary fibrosis, I don't know, but I assume that these tyrosine kinases must be somehow involved, because this is an improved therapy for idiopathic pulmonary fibrosis. Now, the hypothesis here is that we could improve the patient's St. George score if we not only treat them with nintedanib, but also give them sildenafil. That's Viagra. And the doses of Viagra that were applied here, in my view, are not that trivial. These patients got 20 milligrams of Viagra 3 times a day for the duration of the study. And so here's the tyrosine kinase inhibitor alone plus placebo, and here's tyrosine kinase inhibitor plus sildenafil. And here are the poor patients, older patients. Most of these patients were male. Their body weight, pretty thin. Time of diagnosis and their pulmonary function, forced vital capacity, FEV1, markedly impaired carbon monoxide transfer, and their St. George score is not terrific either. And some other scores were also applied here in this study. Now, what we see here is that the St. George score seems to be a little more sustained instead of getting worse over time in the placebo study, but no 4 points. And any improvement at 24 weeks, there does seem to be improvement in the Viagra group, but not 4 points. And so 4 points was the endpoint. The placebo group also got a little better. So even though this group here improved 6.85 points, change in the score at 24 weeks, the placebo group improved 4.44 points, no significant difference. So the St. George scores did not get better in the study, although forced vital capacity got a little bit better in the sildenafil group, but this was not a primary hypothesis, so that the authors couldn't really rely on this result. Diarrhea was the most frequent adverse event. Sex lives were not reported in this study, which I thought was interesting, but don't need to go into that. But sildenafil didn't really seem to help these patients, at least in terms of the primary hypothesis of improving their St. George scores. So we're left with the tyrosine kinase monotherapy for idiopathic pulmonary fibrosis. Then there are some policy papers that I thought were of some interest. In the United States, at least, all hospitals are monitored in terms of hospital-acquired infections. And in 2011, we looked at a report indicating that 4% of hospitalized patients in the United States get a hospital-acquired infection. And as you might imagine, urinary catheters are high on the list. C. difficile is high on the list. Ventilator-related infections are high on the list. If the patient's in the intensive care unit, that's high on the list. Small hospitals are worse than large hospitals, probably because their personnel isn't of the same caliber. All that was known. So in the survey, to my interest, things got better, and the infections dropped from 4% to 3.2%, which is a relative improvement of about over 16%. And what got better is C. difficile got a little bit better, the urinary catheters did a little bit better, the postoperative infections did a little bit better. And so it's worthwhile monitoring these things because improvements can be accrued. And that was indeed the end result in this study. So here we look at an age breakdown of these subjects, and you can look at that in detail if you want. The surgical site infections were notable. The urinary tract infections improvements were also notable. Pneumonias, unfortunately, stayed about the same. And here's a breakdown on the bacteria that are involved, and the usual candidates are listed, as you can see here. So in this point prevalence survey, there was an improvement in hospital-acquired infections in the United States, so that we can congratulate the Americans accordingly. The next topic in the New England Journal was Lassa fever. And Lassa fever is a hemorrhagic fever, viral RNA virus. It's seen primarily in Africa. Contact with rodents is involved here. And there was a large outbreak in Nigeria, which led the authors to conclude that perhaps something had happened in the genome of these viruses to make them more infective. And so we look at suspected cases in blue over a time frame here from 2012 to 2018, and the verified cases in orange. So it looks like Lassa fever is still with us. And then a lot of sequencing was done by 2 different institutions looking at these Lassa virus sequences. And here you can enjoy them in detail in the various counties in Nigeria where the disease was most common. But it looks to me that the genome of the Lassa virus was not that variable in terms of what happened here over time, so that other factors might be involved. And so the authors concluded that it might be involved changes in the rodent reservoir population, or perhaps the disease was more commonly observed because surveillance and heightened public awareness were improved. Review in the New England Journal is cell-free DNA analysis to follow up cancer. This technique goes under the jargon of liquid biopsy. Hate that term, but we're stuck with it. So what we're talking about here are cancer patients and detecting their disease in blood by looking at cell-free tumor DNA. So we have to know sequences what we're looking for. We have to have access to blood. Probably most of these patients have already had a tissue biopsy for tumor so that we can tailor what we're looking for based on what their tumor looks like. And this treatment might have some role in looking at whether or not the tumor is controlled, or if the tumor is progressive, it might save on some imaging techniques that were done. Probably won't, but it could be, that could be a technique. And the authors discuss the technical aspects of this to look for cell-free tumor DNA. And this is coming because the amount of DNA that has to be circulating that can be found with techniques today is very little. And the half-life of this DNA is brief, so that the processing has to be done immediately. But all the details that are involved here is the purpose of this report, to introduce us to the idea that these so-called liquid biopsies are probably going to be a technique that's going to allow follow-up on tumors, whether or not they're progressive, whether or not the therapy is effective, and might spare patients some discomfort from other kinds of techniques that are used here. And the kinds of tumors probably is going to be utilized not only for solid tumors, but also for hematologic kinds of tumors. Looks like this is a rapidly emerging technology, and we should be familiar with it. Then there was a patient described in the New England Journal that has Perrinneau's syndrome. This is Perrinneau described a number of different diseases, but one of the things that he described was oculoglandular syndrome. This involves conjunctivitis, as you can see here, and involvement of draining lymph nodes in the face and neck. And it used to be MTB, leprosy, tularemia, Yersinia, syphilis, and trachomatis were common, but today this is a hallmark of catch-scratch disease, Bartonella henselae. And the patient here is a 5-year-old girl that presents with, they put this black marker over her eye, so you can hardly see that she has conjunctivitis. Brilliant. But you can see these large, this huge periauricular lymph node that she's got here, and she had Bartonella henselae, and her cat had it too. That's nice. Now, the patient in the New England Journal bothered me quite a bit. It concerns a 26-year-old man who comes to the hospital with cough, fever, chest pain, has community-acquired pneumonia, and has a chest x-ray, and cultures are done, didn't help too much. He's treated with antibiotics, and after 5 days he's sent home. Well, he didn't get better. And so this is a patient with type 1 diabetes mellitus, and he's had previous problems with axillary abscesses, skin infections, and problems of this nature. And being an American, he doesn't have an insulin pump. He has to squirt his own insulin, and he doesn't have one of these great cell phone blood glucose monitors either. So he comes back into the hospital, still with the same problem, and this chest x-ray is done. And what we see here is he's got left lower lobe infiltrate. We can see his left heart border, so the ligula is not involved, but he has a substantial pleural effusion seen here. And what I would have liked to have known is what his chest x-ray looked like when he was discharged. I'll bet he didn't have one. So he comes in with this pleural effusion, and a pleural effusion in bacterial pneumonia means that this could be an empyema until that possibility is ruled out. So CT is done, and we can see this consolidation and the poor resolution of that, and we can see this pleural effusion here, and that indeed finally is diagnosed with a thoracentesis, and it turns out it is an empyema, and this patient has to have a chest tube, and he's started on vancomycin and levofloxacin and metronidazole, and is admitted to the hospital. Well, he gets renal failure, and what could it be? And he has an active urinary sediment with all sorts of things in his urine. And blood sugar control isn't very good, and his LDH levels are high, and his creatinine increases to 3.2 milligrams per deciliter, and has proteinuria, and so a renal biopsy is done. And he looks like he has a crescentic glomerulonephritis, and immunofluorescence shows all sorts of staining, and electron microscopy is done, and he's got deposits and capillaries and subepithelial deposits and also subendothelial deposits, and this is a post-infectious glomerulonephritis. Now, the most common or the most well-known post-infectious glomerulonephritis is post-streptococcal glomerulonephritis. There's some resemblance here. His complement level, although he's got complement staining in his glomeruli, C3 level was at the lower limits of normal, and he's got a lot of IgA in this biopsy, and the discussion here is how do you distinguish IgA nephropathy from post-infectious glomerulonephritis with IgA deposits, and the nature of the deposits, and all of this is discussed in great detail. And with treatment of his underlying disease, this condition gradually gets better, but the bottom line here is this, that post-infectious glomerulonephritis, in this case it was staphylococcal pneumonia, should be suspected, particularly in patients that have diabetes mellitus. And I think that more attention should be paid to make sure that the primary pneumonia is adequately treated, and that the chest x-ray has reverted to normal, and that patients aren't sent home with pleural effusions who in reality have empyema, which would make them more susceptible to developing post-infectious glomerulonephritis. In the New England Journal, in the letters, I found this interesting collection of families that have these funny electrocardiograms with this coved ST segment depression, and family trees, and each one of these families, the EKGs, if you look at lead 2, they all look the same. And this interested the authors to a great degree. Look at these things. They suggest that this could be genetic. And so they did a genetic analysis on about a whole palette of genes that have been associated with long QT syndrome and Brugada syndrome and a whole bunch of other things. Didn't find anything. The genetic evaluations were performed at the discretion of the referring physician. I guess that's okay. But what bothered me is that the authors didn't do a linkage analysis. And look at all these family trees. It looks like it's autosomal dominant disease. They need 500 microsatellite markers or a SNP analysis to try to find the gene locus here. So I sent the authors an email and asked them why they didn't do a linkage analysis, but I got no answer. The next topic is pupils. And this young lady has constricted pupils above and dilated pupils below. And we know that this involves a muscle called the ciliary body, and parasympathetic stimulation results in pupillary constriction, and sympathetic stimulation results in pupil dilatation. And there are some classic things. It used to be when patients with glaucoma were treated with pilocarpine, they all had pupils that looked like that, except of course the patients were much older. Two other drugs that cause constricted pupils are opioids and organophosphates. And the drugs that cause dilated pupils, there's a whole list shown here. So clinicians, particularly working in emergency rooms, need to be aware of these things. Because here are patients, a whole bunch of patients, I think this was in Philadelphia, came in acting peculiarly, and they all had pupils that looked like that. And most of their urines were positive for cocaine because they'd been smoking crack cocaine and doping themselves up with fentanyl, which is an opioid that results in constricted pupils. And there was a whole epidemic of these patients coming into these emergency rooms in Philadelphia. They all had the same zip codes, so presumably they were all getting fed by the same dealer. And these weren't chronic drug addicts, and these weren't teenagers. These were patients in their 50s. Americans are amazing. The next topic in the New England Journal was healthcare in the 2018 election. That was yesterday. And so what was done here is an analysis was done of Republicans, Democrats, and total voters on what are the things that related to healthcare that bother the electorate. And we see that 40% of them are worrying about their healthcare. 39% of them are worrying about gun policy. Half of those want more guns, and the other half want less guns. Then the Supreme Court nominees are important: economy and jobs and education. I thought was interesting is we can contrast the Republicans from the Democrats. The Republicans are worried about terrorism. I think terrorism is bad too, but the chances of being killed by a terrorist in the general population is about as great as the chance of being struck by a meteor. But this bothers the Republicans. They're worried about gun policy, but they want more guns. And then they're terribly concerned about immigration, and they don't want to pay any taxes. The Democrats are a little different. They're worried about health care, education. They're worried about the Supreme Court being stuffed with conservative judges. They even think about the environment. And they're also concerned about gun policy. And so you can look at differences here. At least being an American, it was interesting for me. So another big issue in the United States is abortion, at least amongst politicians. But amongst the population, a majority of overall registered or likely voters believe that abortion should be legal in all or most circumstances and agree with the 1973 decision of the Supreme Court called Roe versus Wade. However, the Republicans want abortion restriction, and they're probably going to get the Supreme Court to overturn Roe versus Wade. This is a side issue, I would think, but the Americans are fun to watch. Here's a question of the week. It involves how do we deal with a 52-year-old man that looks like he drinks too much. At least he's got elevated, he has 30 drinks per week. Not so bad, but he's got elevated liver enzymes, and we're asked what to do with him. Should we tell him not to drink any alcohol anymore and take disulfiram? Surprised that's still on the market. Abstinence from alcohol, that sounds like a good idea. Or perhaps we should get him down to 14 drinks a week, cut it in half. Or perhaps he should have abstinence plus naltrexone. Or perhaps 14 drinks a week plus disulfiram. Well, the problem is if you take disulfiram and have any drinks, you get violently ill. So that last one isn't probably a good idea. But what's naltrexone is now approved in the United States for alcohol dependency because it results in less craving. And in the German literature, naltrexone is also accepted, so that's the right answer. In the Lancet, the topic is stillbirth. And this is a very sad and unfortunate condition where mothers sense motion of a fetus, that's called quickening in English, and if quickening gets less or stops, this is a danger sign that stillbirth could possibly occur or has already occurred. And there are fetal reasons for this, and they're very most common. There are also maternal reasons for this: infectious disease, toxoplasmosis, cytomegalovirus, eclampsia, HELLP syndrome, diabetes mellitus, drug abuse, and things of this nature. And how this should be diagnosed is a matter of debate. And in this large study in the United Kingdom, centers were randomized. As I recall, this was a cluster randomized trial. And the intervention here was an e-learning educational packet for all clinical staff in the participating hospitals about the importance of recent change in the frequency of fetal movements and how managed intervention. Pregnant women were given a leaflet to make them aware of this potential problem, and a management plan was suggested in case fetal movements seemed to be decreasing. And the other option was leaving the people alone. And so we hear a lot of live births here, 226,800 some, and in intervention control group 156,900, and other variables in these two groups were not significantly different. I haven't listed them all here, but what happened to these women was different. Whether or not they underwent cesarean section was more common in the intervention group. Whether or not labor had to be induced was more common in the intervention group. Elective delivery at 39 weeks or spontaneous vaginal delivery was less common in the intervention group compared to the control group. These things are not favorable. Then I had to go to the supplement to find out what was wrong with these fetuses. What resulted in stillbirth and neural tube defects, anencephaly, hydrocephalus, awful things, cardiac defects, circulatory system, all listed here. The table was fairly small, so it's difficult to read. But these infants that exhibited stillbirth, at least large numbers of them were severely malformed. So, added value, this intervention seemed to cause more problems than it solved, and that's so that this intervention packet cannot be suggested for pregnancies in the general population. Then the next study was a big epidemiological study of stillbirth in 19 European countries, and Germany is also represented here, and you can look at that. And whether or not stillbirth seems to be decreasing over time. Austria is doing better than Germany for reasons that are not. Finland, here's Germany, matters in Germany have not got better, but matters in Austria have. So it can't be a language difference. Don't understand that. The authors didn't comment on that further. But stillbirth is an important topic, and an editorial underscores the fact that these pregnancies should be monitored and some healthcare conclusions about them should be reached. Then Lancet is a UK journal, so they're interested in global burden of disease in the UK, and how things were in 2016 compared to 1990. And so the British looked at that, and you'll never guess how this comes out. Low back pain, skin disease, migraine, depression, DALYs, and years of life lost for quality and these various things if you're in, and here they are. Tobacco, dietary risks, high blood pressure, alcohol use. It looks like England, Scotland, Wales, and North Ireland are indistinguishable. The soccer teams are different, though. And the poor Scots are a little sicker, probably based on the climate, than the rest of the UK. And we don't know about the Irish. Now, are there correlations, high body mass index and age-adjusted standardized rates of adverse events and dietary risk and tobacco and systolic blood pressure? But I think we all knew that earlier. So, despite all this terrible news, life expectancy is getting better. And in the UK, if we look at Scotland, the Scots are always, poor Scots, but even they are getting better. And everybody's getting better at the same rate, so that the males now have an option of maybe making the 82-year mark. The females do a little better than the males, and they got better also. And we can look at individual conditions as they go up and down. But the same variables are afflicting the population, but nevertheless, the population in the UK is getting better. Now, the reviews in the Lancet are important because one of them is on hip replacement and the other is on knee replacement. And hip replacement is getting more common, but the population is getting older, and osteoarthritis is getting to be more common. But the good news is that the numbers of revisions that have to be done is decreasing over time because the technical aspects of this particular operation have gotten markedly better in every respect, and that's what this review is about. So cumulative revision rate for cemented, cementless, and hybrid prostheses is about the same. But I mean, after 17 years, if the revision rate is under 8%, I think that's pretty good. And knee replacement, same pattern. The disease operation's getting more commonly in terms of total or partial arthroplasty, but what the surgeons have to offer patients has gotten markedly better. The age distribution that we can see here, but even patients that make 100 are now being operated on if they're otherwise okay and would benefit from this operation. And the lifetime risk of revision is also decreasing, even as a function of age. And the number of operations, I don't know what the Portuguese are doing here, whether or not they have more arthritis. I wouldn't think so. Don't quite understand these data, but the operation is common and the indications have been loosened somewhat. Quality of life, pain, mobility, problems of this nature. And there are priorities for research in osteoarthritis, and we need to think about those. And new technologies are coming along that are much better. And the conclusion is that it looks like this operation is also here to stay. I also picked up a paper out of JMA that interested me because lanreotide is a somatostatin, and somatostatins do many things in the body, but they also inhibit adenylyl cyclase. And somatostatins were suggested in animal models and other kinds of studies as that they might inhibit cyst progression in patients with polycystic kidney disease. And that hypothesis was tested in a randomized trial. This was begun already in 2011, and the results are unfortunately negative. The decrease in glomerular filtration rate was the same in the control group compared to the somatostatin group, and so there was no benefit here. Then we close with a patient with fleeting blindness, that's called Amaurosis Fugax. And this patient had an attack of Amaurosis Fugax while undergoing fluorescein angiography, which sort of gives us a clue in terms of the etiology of this condition in this patient. And what we see here is a marked diminution in blood flow with fluorescein angiography that then gradually recovers within seconds over time. And we can look at these projections here, implying that this episode is due to vasospasm. So this patient was treated with nifedipine and got substantially better. So sometimes you're lucky and you can observe diseases as they happen. Thank you very much for your attention, and see you next week. And if you'd like to hear all this in German, stick around.